Now going to welcome to the podium Dr. Jason Katz. Dr. Katz is a professor of medicine at NYU Grossman School of Medicine. He is Associate Chief of Cardiology and Director of Inpatient Cardiology at Bellevue, and he's going to talk about vasodilatory cardiogenic shock and the role of percutaneous mechanical circulatory support.
Good morning, everyone. Excited to see you all here. I love it when Marwin gives me talks with no evidence base behind it. It makes it quite easy to wax poetic, so that's what I'm going to do here. Here are just a few of my disclosures. Remember when life was so simple? I think that all resonates with us right now. Remember, there was just like one definition for cardiogenic shock, right? It was just a low cardiac output state leading to end organ hypoperfusion, resultant tissue hypoxia, and its sequelae. And hemodynamically, it was manifested by a low cardiac output and a high SVR. That's what we were taught in medical school. That's what we were taught during residency. It was simple, but for many, many reasons, life has become so much more complicated. I show this slide for two reasons, usually. One is just to show the diverse pathology and pathways leading to decompensation associated with cardiogenic shock, where it's not just a pump problem, it's not just a vascular problem, but includes an inflammatory cascade as well. And the other reason I show that this is sort of for job security. Always show a slide that makes your job look a lot tougher than it is. And somehow, we're able to intervene on that vicious cycle leading to death to save a number of lives. Again, there was initially one real phenotype of cardiogenic shock that we used to describe, right? A low cardiac output, high systemic vascular resistance, elevated cardiac filling pressures. That was classic cardiogenic shock. And that high SVR was in part compensatory, right, to preserve systemic perfusion pressure, to enhance coronary blood flow, and to improve microvascular driving pressure. But it was also pathologic too, right, at the expense of an increased afterload to an already challenged heart. But then we've identified other phenotypes for cardiogenic shock, the euvolemic phenotype, and also this sort of vasodilatory or mixed type of shock, where you have low cardiac output, you do have elevated cardiac filling pressures, but normal or low systemic vascular resistance. And while we've been just talking about this more recently, this isn't a new finding. Like in Judy Hockman and colleagues' initial seminal shock trial and the resultant registry, they saw this as well. Up to about a quarter of patients had this clinically evident vasodilatation, where the SVR wasn't particularly high, elevated, or might have been somewhat low. And then in a subsequent small secondary analysis, they separated patients within the shock trial and registry into those with high SVR and those with low SVR. And there was certainly a signal that those with this perhaps maladaptive vasodilatation had worse outcomes, in this case 30-day mortality. In more contemporary, largely observational series, we've seen this too. This from the Critical Care Cardiology Trials Network among very high volume cardiac ICUs within North America, looking at hemodynamic variables associated with outcomes in cardiogenic shock, and again highlighted systemic vascular resistance as a potent predictor of outcomes, such that this, again, maladaptive vasodilatation or low SVR was associated with worse outcomes. And interestingly enough, a more potent predictor of mortality than cardiac output or cardiac index in this observational registry. So I got this topic and I was, just to be transparent, confused. And I don't want everyone else to be confused here, but there are various nomenclatures to this concept. And what we're asked to talk about, what I was asked to talk about, was vasodilatory cardiogenic shock. Not mixed shock, not cardiac vasodilatory shock, but vasodilatory cardiogenic shock. You got it? What does that mean? I had to do a little due diligence research, right? So we're talking about vasodilatory cardiogenic shock, and in a couple of sort of seminal reviews by Jake Genscher, Sean Van Diep, and others, they highlighted this vasodilatory cardiogenic shock as an event where there's a primary vasodilatory insult, such as in sepsis or toxidromes or following cardiac arrest or in endocrinopathies, with a secondary myocardial dysfunction and resulting low cardiac output. So the vasodilatation started, and then the cardiogenic component followed. To be differentiated from cardiac vasodilatory shock, in which there's a primary cardiogenic shock with this sort of secondary or, again, maladaptive vasodilatation, or mixed shock, which suggests sort of a combined vasodilatory and cardiogenic shock insult. And then I was asked to talk about percutaneous mechanical circulatory support in this vasodilatory cardiogenic shock, and as you can imagine, it's a fairly evidence-free zone. But again, there's observational data that suggests that patients with this type of phenotype, at least mixed cardiogenic shock in the Critical Care Cardiology Trials Network, physicians, clinicians who take care of these patients do frequently leverage percutaneous MCS. About 1 out of every 5 patients with this type of shock phenotype were managed with some type of percutaneous MCS strategy. So what strategies might those be? Again, there's no data, there's certainly no randomized data showing head-to-head comparisons of different devices for these patients. So, we often talk about matching the right device to the right patient at the right time, or the right pharmacotherapy to the right patient at the right time. So trying to leverage the beneficial effects from a hemodynamic perspective to the pathologic insult that the patient is dealing with. So, balloon pump's probably not an ideal device for this. Remember, it intensifies diastolic blood pressure and reduces systemic vascular resistance, and we're talking about a state where there's already this untoward reduction in systemic vascular resistance. We're probably not an ideal device. Perhaps in certain patients, in certain patient phenotypes, a percutaneous VAD like the Impella platform of devices or VA ECMO certainly could be physiologically plausible, because they, at least the PVAD, will directly unload the ventricle and help to improve cardiac output and systemic perfusion. And VA ECMO, for a variety of reasons, can enhance systemic blood flow to quite a marked degree. It pressurizes the aorta. It won't necessarily reduce systemic vascular resistance thoroughly, and improves end organ function, acid-base status, ischemia, all of the things that might help a patient in this scenario. And then I started thinking about this. This seemed really eerily similar to another talk I was asked to give at the Houston Shock Symposium 2 years ago, where I was asked to talk about ECMO specifically in septic shock. And I was like, perfect, that's less slides that I have to put together. And I just want to remind you what I said then. I said, why might this make sense, or why might this not make sense? Well, this is, primary sepsis or septic shock is a purely vasodilatory condition, often associated with a hyperdemic cardiac function, with normal or even high cardiac output. ECMO doesn't really improve vascular tone, doesn't really enhance endothelial function, doesn't really reduce vascular permeability. And for a variety of other reasons, it doesn't sort of make sort of intuitive sense. Maybe it can help improve systemic blood flow, and maybe you improve systemic blood flow enough that'll help, even though this is really about oxygen utilization and metabolism in a purely vasodilatory state. Now, maybe if there's concomitant cardiac dysfunction, you can help attenuate that with ECMO. Maybe it can be a bridge until the antimicrobial therapies or other interventions, anti-inflammatory interventions, are utilized. Maybe adults really are just big kids, because there is a little bit more robust data in the pediatric population and the pediatric septic shock guidelines. And I showed a couple of observational series, this from 5 academic centers, 82 ECMO patients, all patients with ventricular dysfunction and a low cardiac index, and a propensity score matched analysis suggests that perhaps VA ECMO could improve outcomes in patients with septic shock. This, a meta-analysis, a systematic review looking at septic shock patients, highlighting again that perhaps in those that had really reduced ejection fraction, so concomitant myocardial dysfunction or septic cardiomyopathy, this is where VA ECMO might be potentially beneficial. I'll remind you that none of these were randomized controlled studies. None of these were even prospective analyses. But I thought this was kind of timely. This was a text string that went out just probably about a week ago among the critical care cardiology group that, talked. So I thought I'd show a few of these things. And someone asked, hey, are you routinely using VA ECMO in septic cardiomyopathy patients? And the first said, I'm trying to avoid it. And it seems perhaps that if low cardiac output is dominating the picture, maybe it will enhance outcomes, probably will worsen outcomes in a lot of cases. I agree with Tom, said Ricky Hansra, but it's not a common practice. We've done it about 5 times, really in young patients, and in those patients it tends to we've had some good success. Anik at Raleigh, who's here in the audience, got some data coming out on systemic perfusion and ECMO from the ELSO registry. Let's wait on that. And then, of course, Connor O'Brien, who's excited about everything, and you'll see him in just a couple of minutes. He said, yes, more ECMO in sepsis. So this is a common issue that we're all sort of sort of tackling or trying to tackle at this time. So in conclusion, mixed cardiogenic shock, including this specific phenotype of vasodilatory cardiogenic shock, is not uncommon, and it is associated with worse outcomes. There are no randomized and very few prospective observational studies evaluating percutaneous MCS options in this particular phenotype. While the pVAD, including specifically the Impella platform of devices, might be feasible in certain patients, it might also not be feasible. A lot has to do with patient physiology, pathophysiology, anatomy, etc. VA ECMO may perhaps be a better choice in select individuals, particularly those with concomitant cardiac dysfunction with particularly low EFs, to allow for better systemic perfusion, more robust cardiac output, and the attenuation of all those other secondary sequelae, acid-base disturbances, ischemia, end organ dysfunction. But remember that once you put these devices in, the clock starts ticking on all the potential adverse events. And furthermore, we do know that these percutaneous devices can exacerbate inflammation, which may already be driving the vasodilatory cardiogenic shock picture. They can enhance bleeding risk, to be sure, and they can contribute to the ongoing infection risk, vascular complications, et cetera, that you're already trying to avoid. Shameless plug, we have a new journal, Journal of Cardiac Failure Intersections. I would be remiss if I didn't include that. Would love to see your work, particularly in areas just like this. So thank you.
It was a wonderful, nuanced discussion in an area that comes up all the time and that we really, really are lacking evidence. I'd first like to go down the panel and just find out amongst this group who is using percutaneous MCS in this patient population.
I'll say that yes, we do. Selectively, I think, as Jason mentioned, it's and we tend to do it more in younger patients. I tend to choose if we think there's a reversible process. We've had a couple, for example, who were had active pancreatitis in shock, and there was a cardiac element to it. We went ahead and put them on ECMO and let the pancreas cool down for a little bit, and we're able to wean them off. One thing that I would maybe consider in some patients, although you mentioned the Impella may not be the right platform, but in some selected patients, we've actually did a sort of bipella or propella, Impella and then Protect Dual on the other side, just to allow them to mobilize a little bit more if we had time to do that.
We have a question from the floor.
Yeah, thank you, Jason. This is Arvind Bimraj from Methodist. Thank you for a wonderful talk, very elegantly put forth, even though there's no evidence. My question to you is, sometimes we are ruminating on the hemodynamics quite a bit in the field of shock because that's what we know. And my mentor, David Taylor, said, you leave a swan in and see somebody with cardiogenic shock die, they will die of low SVR, not high SVR. So my question to you is there some way of figuring out a relative SVR to cardiac output? Because there are situations where you have these patients where the heart is bad, you know that, but then the hemodynamics in a relative setting show you that the cardiac output is normal, and we're debating, do you put in an MCS or not? And then you lose the opportunity. So is there a window of this vasodilatory spectrum which is being driven by the heart? Because we don't understand the cardio-neuro mechanisms as much.
Ooh, that's a loaded question. Yes. I think you bring up a lot of really interesting points, to be sure. And, at the end stage of cardiogenic shock, at the end stage of almost any shock, with multi-system organ dysfunction and unrelenting systemic acidosis and acidemia, you see a low SVR, right? That is sort of an end-stage manifestation. I think it highlights, to your point, being thoughtful and early about the potential intervention for these patients. I think that's where multidisciplinary collaboration comes into play. I think that's where shock teams can be potentially beneficial. I think that's where further investigation, as you sort of highlight, makes a lot of sense. I think we oftentimes, I had a mentor that told me that when it comes to invasive hemodynamics or anything that happens in the cath lab, it's all a lie. Right? It's all approximations based on assumptions, based on patient positioning, based on physician interpretation. So, we rely very heavily, we're starting to really rely very heavily on these invasive hemodynamics to help us guide our MCS selection. But eventually you got to realize that's one piece of information that we aggregate together with all the other pieces of information on these critically ill patients. And I think sometimes you have to well, I gotta give you the PG version, poop or get off the pot, right? I mean, you have to sort of make an intervention, make a decision, and be prepared to deal with the consequences, positive or negative, about that. But I think that's an area sort of ripe for investigation, to be sure.
I got one question. Would you, not a question, just would you spend some time talking about septic myocarditis? Is it relevant in this situation? How long does it last? It's days or months, and which device would be appropriate in the situation?
Yeah, I mean, I think this is where most of the data exists in the vasodilatory cardiogenic shock space in patients that happen to have sepsis, septic shock, and have a concomitant cardiac depression, right? I mean, Steve Hollenberg has researched this a lot. He's far more an expert on the septic cardiomyopathy, septic myocarditis picture. I know enough to know that terminology exists and the illness process exists. And those are probably the patients, again, where we should be thinking about leveraging these devices because they tend to be younger. They tend to hopefully have the opportunity to recover, particularly if you support them well enough and you support their end organ function well enough. But Steve, I think you should weigh in on this.
Yeah, I think I agree with that. I think to the extent that you think you have a septic cardiomyopathy, that in that context, supporting the left ventricle without necessarily going all the way to ECMO with bleeding and such. The challenge there is that classic septic cardiomyopathy is reversible and is going to get better in 7 to 10 days, and you can usually ride that out. But the further challenge is that, so remember, the first definition of septic cardiomyopathy was in young people who really didn't have any reason to have pre-existing left ventricular dysfunction. When it's in your unit and it's somebody who's 75 years old and doesn't seem to have a good ventricle, it gets a little more challenging to see whether some of this was pre-existing, all of this was pre-existing. But to the extent that it is pre-existing, then it might not reverse so fast, and you may need left ventricular support.
Two questions to follow this. What's about right ventricle? Is it affected more, less, or the same? And if we speak about septic, it's a bacterial. What's about virals? Because we have some cases back in Berlin with influenza myocarditis put on ECMELA, and recovered at Integrum.
So, all right, I'll go to the second one first. So it's a little bit of the story of the other day. In general, the sort of infection doesn't appear to change the incidence and the presentation of septic cardiomyopathy, except if the virus is, and is a little bit of a continuum between myocarditis and septic cardiomyopathy. You can see a little bit of inflammation, but in general, that was felt to be circulating stuff. But if you have a virus that is affecting the heart, now you have viral myocarditis, and that is sort of a different animal from septic cardiomyopathy. So I think that that's a little bit different in that context.
Great, thanks. Yeah, great talk, Jason. I think we also have to differentiate. We'll put them on ECMO as well, or other percutaneous support if it's something very that we think is reversible. They're young, but I think if it's the end-to-end stage heart failure patient that's lost vascular tone due to hemometabolic shock, it's likely too late.
Yeah,
Number
agreed.
one. Number two, we always have to also rule out shunts. We have to rule out liver failure, liver disease, as potentially not a patient that might benefit from ECMO because they might not have an exit strategy. And then lastly, we've seen this pretty cool phenomenon. Well, it's really not cool, it's very perplexing, but we're looking at it at Penn, BMI and adiposity and SVR, because these really extremely obese patients that we see, the fat cells don't need to be perfused. They almost have like a shunt-like hemodynamics with a super low SVR, but it's really just a calculation. We just keep their maps up and ignore the SVR and treat the blood pressure in the end organs.
Yeah,
I think that's a really important point. So to me, and Arvind too, to me, SVR is a calculated value. It's a function of pressure and cardiac output. And essentially, I think it's just as good to think about what is your pressure and what is your cardiac output and where is your problem. You don't really need a calculation of SVR to try to sort out which is more important in different contexts.
100%.
I also just want to add that as we're seeing more immune checkpoint inhibitors, I find that those immune checkpoint myocarditis has a vasodilatory component to it as well. And so I think we're going to see more of it in a different context where they look different and it feels a little bit different.
And in our center as well, to answer your question, we have a multidisciplinary approach. Septic shock, as we know intuitively, physiologically, causes myocardial depression, causes significant vasoplegia, has significant short-term vasodilatory effects. All of those can be used via ECMO for that. We do talk about them, and we have successfully used that in our center as well.
And I would just add, we're all here. We all try to save lives. That's why we're here. And we'll oftentimes go outside the box, sometimes way outside the box to do so. The body has a unique way of telling you when you're wrong, though. Like when you put someone who doesn't need a particular percutaneous MCS device or option, you put it in someone that doesn't need it, the body tells you very quickly that you did the wrong thing, and then you deal with those consequences. Am I right, Steve? All right, thanks.
Thank you, Dr. Katz.